phone, and I'm just going to remind people that the session is being recorded, and that we will do questions at the end. If you want to put them, I think there's a chat box. If you'd like to put questions in the chat box, and then we will address them at the end of the session. I'm really happy today to welcome Dr. Megan Mcneil, geriatric psychiatrist in Central Zone. Dr. Mcneil did her residency and subspecialty training here in our geriatric psychiatry program, and is currently our inpatient geriatric psychiatrist at the geriatric inpatient unit, and actually leads this particular group in terms of doing the web education. So thanks for joining us, Dr. Mcneil. She's going to be talking about bipolar disorder in the elderly today, and welcome.
Thank you so much. Sarah, I'll just get the slides up. Okay, get things arranged. Okay, we're good. So like Sarah said, my name is Megan Mcneil, and I'm a geriatric psychiatrist working at the Geriatric Psychiatry Acute Inpatient Unit, known as Willow Hall. Today I'm talking about bipolar disorder. This is an updated lecture that was created with Mark Bosma, myself, Alison Torin, and Leanne Revel. It's been updated with the 2023 bipolar guidelines from CanMat, and I made some tweaks here and there. But if it's familiar, there is a good reason for that. So our objectives today are to review the clinical features of bipolar disorder in the elderly, including the epidemiology, the etiology, differential diagnosis. We'll look at the clinical presentation in older persons with bipolar disorder. And also we will look at the treatment approaches, and we'll do that through case examples. So the diagnostic criteria and the mood episodes comprising bipolar disorder are the same for younger folks. So, and the episodes that mostly comprise these diagnoses are hypomania, mania. So this is the higher elevated mood spectrum, and then depression is the lowest end of the mood spectrum. So these are the episodes that you need to have to meet the criteria, depending on which constellation of these episodes you exhibit. And so these specific episodes, without beleaguering the basics, but I think it is important to build from the basics, as we have a varied audience with this group. So to have either a hypomanic or manic episode, they have very similar criteria. A manic episode is a distinct period of an abnormally elevated mood. It can be expansive, and you also have to have either increased energy or increased activity. It has to have a duration of at least a week. And these symptoms have to be there for most of the day, nearly every day. But if you end up in hospital or you have psychotic features, in addition to meeting the other criteria of a hypomanic episode or a manic episode, it's clearly then diagnosed as a manic episode. So there are other features that we looked for. The mnemonic that we often use is dig fast, and it's listed here. And you have to have at least 3 of these symptoms to meet the criteria. They have to be there during the duration of the illness. So decreased sleep, increased or fast speech, racing thoughts or ideas that change really quickly, being distractible, increased activity, and increased risky behavior. This often looks like increased sexual desire, increased spending, increased use of substances, and sometimes people will drive their car really fast if they're still driving. If you have a mood that is irritable, it's not elevated, but it's irritable, that also can qualify, but you need more symptoms. You need 4 of these symptoms. And so if you have a manic episode that does meet the criteria, if there's not another explanation for it, like another illness, either psychiatric or otherwise, then it is manic then it is a bipolar 1 disorder. If you only have a hypomanic presentation in combination with a history of depression, that would be a bipolar 2 presentation. The difference between the hypomania and the mania is that hypomania is less severe. So you don't have to have the symptoms for 7 days. And you need to have them for 4 days, and it's not severe enough to cause marked impairment in social or occupational functioning, which you would need for the diagnosis of mania. So then looking at the other side of polarity, a major depressive disorder, and this is MCGCAPS is a common mnemonic that we use. You need 5 out of the 9 symptoms, and they need to be present for 2 weeks. One of the symptoms has to be either low mood or decreased interest. But you could have increased or decreased sleep, guilt, low energy, low concentration or impairment in concentration. You could have appetite that's increased or decreased. You can have slowing of your psychomotor, your movements, or you can have agitation. And suicidal ideation is also a core symptom of depressive disorder. So when you think about all of these things, it's useful to think of it on a spectrum. So these are all of the mood episodes that you could have. Of course, there's a normal somewhere in the middle, but at the one pole, there's major depressive episodes. At the other pole, mania, hypomania. And then on the lower end, below normal is dysthymia. And then the associated disorders are listed here. So bipolar type, you have a full spectrum of presentations that you usually see, though not necessary for diagnosis. For bipolar 2, you have to have the major depression and the hypomania. In cyclothymia, which is also bipolar spectrum illness, you don't meet criteria for major depression or for mania to meet the criteria there. So moving on to just a little bit of information about how frequently we see these disorders. So the prevalence can vary from source to source, but the 1-year prevalence of patients over 65 is about 0.4%, which is lower than the point prevalence in the general population. Overall, this is not the most common psychiatric disorder by a long shot. The lifetime prevalence, if you look at people over the course of their lifetime, of course, is higher, but it's more common in clinical settings than in the general population. So higher percentages in nursing home residents, it's really quite a bit higher in geriatric psychiatry inpatients. And when you look at the demographics of bipolar patients as a whole, there's a good proportion of those patients that are above 65. And we do know that that is increasing with demographic changes. So the mean onset, so usually most patients have their first episode of either depression or mania as young adults. But there are a small number of patients who present later in life, and we think of late onset bipolar disorder as a diagnosis after age 50. And in those patients that have that late presentation, they are more likely to be female, whereas in a younger population, the female to male ratio is 1:1. So we'll talk a little bit about how we think bipolar disorder arises. And the short answer is we don't really have a good understanding why specific people develop this disorder. We do have some hints of things that are different about these patients. We do know that there's not a single gene that causes bipolar disorder. But we do know there are many genes that increase the likelihood of bipolar disorder. And we do think that these genetic factors interact with environmental factors that lead to the development of bipolar illnesses. The disease process that causes this is thought to involve inflammation in the body, might possibly have mitochondrial function changes and have oxidative stress. We think that episodes of these mood episodes may be toxic, causing further episodes. We know that stressful life events are more common in those people with bipolar disorder, and may be a factor. When we look at specifically elderly individuals, there are some more common structural brain changes, for example, vascular lesions on brain imaging. There is reduced gray matter in the brains of these patients, in the frontal lobe and the subcortical structures. And there's also, they have a more likelihood of elevated inflammation compared to younger people. And medical comorbidities in general are quite common in bipolar patients, and they are more common in geriatric patients. It's unclear if this is causative or just associated. But there are some differences between the younger patients and the older patients, which we will get into next. So when you look at the clinical features of older patients with bipolar disorder compared to younger, the older folks have more physical illness, they have more cognitive dysfunction. So cognitive dysfunction is common, and there is an increased risk of dementia in patients with bipolar disorder who are older. The way that the bipolar disorder presents, we think, is less severe. So the episodes themselves are less severe, but more depressive episodes. And in this population, interestingly, there's lower psychiatric comorbidity and lower family history. So moving to the differential diagnosis. So, if someone has a lifelong history of bipolar disorder, that's going to be pretty high on your differential if they present with a mood episode. I think where it becomes more tricky is when there is a new onset or not a clear diagnosis. There may be a history of bipolar disorder that was not discovered or identified or treated. So when someone comes without that diagnosis, we want to keep a wide differential. And there are some disorders that do have presentations of disinhibition and impulsivity that can look like mania. Neurological conditions certainly are some of those. It's not uncommon that we see people with multiple sclerosis, stroke, brain tumors, mild traumatic brain injury that could the consultation question is, does this person have late onset mania? Much more less common are things like encephalitis, and those people are usually pretty sick, but it is good just to be aware of that. Same goes for STIs that do have CNS involvement, so in central nervous system involvement. If they affect the brain, they can cause something that might look like mania, like HIV or neurosyphilis, and we're less likely sometimes to think about these disorders in geriatric patients. Just because of bias that we bring to working with older people. Sometimes that can just slip our mind, so it's good to talk about it here. And certainly endocrinological problems like hyperthyroidism, that can look like mania, and hypothyroidism can look like depressive episodes. So overall, it's good to do a thorough history of presenting illness, including the course of an illness that can help out. Having a good past psychiatric history, having a collateral history when possible. A medical history is important. Sometimes we can forget about thyroid, but that's very important in mood presentations. And make sure that there's a physical exam done and appropriate workup. And this will all help with missing a medical diagnosis. In keeping with this theme of other things that could look like bipolar disorder, any neurodegenerative disorders that cause impulsivity and disinhibition can look like mania. So Huntington's disease, usually there's some hints that there's excess movements, family history, but not always. So again, good to think about. Basal ganglia calcification, that's less common. Frontotemporal dementia is the one that we actually get more questions about, and it can be a little bit tricky to sort out. So this is a helpful but a little bit of a busy slide that differentiates what bipolar disorder and FTD, like what's similar, what's different about each. But I think looking at overall, FTD doesn't usually have the same elevated mood. People are not as grandiose. Activity is not usually as goal directed. It's not like someone has a lot of big ideas. Usually their increased activity is more perseverative, less functional. So if someone has a severe mania and gets really disorganized, that can really look not functional. The other features that we see in FTD, like withdrawal and apathy, those often occur simultaneously with the disinhibition, which is helpful in figuring things out. And then the course differences are important. Is this something that's been progressively changing over a course of years, or is this something that has happened more subacutely? So in bipolar disorder is episodic, so we're seeing episodes of mania. We sometimes family history is really important. Is there a family history of FTD or dementias that were have features of FTD? Is there a family history of bipolar disorder? And some of the other things that we can do is look at the cognitive symptoms. This can, again, be tricky. But if someone has something like language dysfunction, that's very helpful. It's unlikely that's related to bipolar disorder and would be more in keeping with FTD. And then if you're going to treat somebody, if you give them antidepressants, they get worse, you might want to think about mania. And then another part that we haven't talked about, you definitely in taking your history, you want a good medication history. We shouldn't forget about substance-induced manias. So steroids and stimulants are classic causes. People with Parkinson's who are prescribed dopaminergic drugs or dopaminergic drugs for restless leg syndrome, that can cause impulsive behaviors. That can look a lot like mania. There could also be a substance-induced mania with these medications as well. And then there's the antidepressant medications that can precipitate manias, but in DSM terminology, we think of these as actually mood presentations. So I'm not going to say too much about the differentiation between late onset and early onset. The evidence is rather mixed. There are some reports stating that late onset bipolar disorder is more likely to have extrapyramidal symptoms, impairment in executive functioning. This is difficult because of the differential, right? Sometimes, are we seeing someone who has late onset bipolar disorder without a dementia, or are we seeing someone with a new onset of a mood episode in the context of dementia? So these are classically tricky cases that need thorough assessment to try to differentiate the bipolar disorder from dementia or establish comorbidity. We do know in general, so for all older geriatric bipolar disorder, there is an increased risk of dementia. And that's twice the risk compared to patients without bipolar disorder. Even comparing these patients to major depressive disorder, they have increased risk. Mortality, we know, is this is a severe illness that has significant impacts on the course of people's lives. So mortality is higher in all patients. There's a decreased lifespan by about 10 years. Part of that is related to suicide. in comparing younger folks, they have a higher risk of suicide, 20 to 30 times compared to the general population. That's a little lower in the geriatric population, but it is still orders of magnitude higher than the general population, and quite significant. The other aspect of mortality certainly is thought to be related to the high medical burden of these patients, and may be related to lifestyle contributing factors, but could also be related to our treatments for these patients. So next we're going to move on to the cases. So the cases are really going to help structure kind of some of what we've already talked about, but also structure how we go about treatment. So this is a case of mine from many years ago now. So the guidelines weren't out when we did when I saw this person, but the case stuck with me. He's a 74-year-old widowed man. He's a retired firefighter. He was admitted to a peripheral hospital for the second time. The referral question was diagnostic clarification. The differential was delirium, dementia, and depression, which I did not mention delirium earlier. This is probably one of the more common differentials that we have to come up with, just because of, again, people can be disinhibited and have increased energy in delirium, like a hyperactive delirium. So it is tricky, but delirium, we think of the main issue as being the course of attention. And there's lots of, like there's the 4AT that you could do a structured assessment just to help you figure out whether it's delirium or not. And you're going to look for medical causes. So our gentleman, E.G., he'd had a 2-month history of cognitive symptoms. He'd had functional decline. He'd had changing cognition. So on his previous admission, he had an MMSE of 16 out of 30. That improved to 25 out of 30 with supportive care and the initiation of an antidepressant. Geriatric medicine on readmission had been consulted and diagnosed him with delirium. But everyone was aware, including geriatric medicine, that there was a lot of depressive symptoms and they needed to be treated. When he had returned home, he became quite disinhibited. His behavior seemed odd. He opened the door of his house to a neighbor not properly dressed, which was definitely not in keeping with his baseline. So he was admitted to hospital, and on the course of the hospital, he just lost functioning. He came in, doing some BADLs, but really needed assistance with bathing, didn't know what to do with a face cloth. So very, very severe. In our interview, it was difficult. He couldn't tell me much. So it was mostly a mental status exam. The only thing he really endorsed was auditory hallucinations. But on mental status, he was alert. He kept eye contact. He was well groomed. He was appropriately dressed. He was sitting in a chair, but severely psychomotor slowed. He didn't move much at all during this assessment. And when he did, I tried to do some neurological exam. He did the opposite. So I asked him to open up his mouth, and he covered his mouth with his hand, which I call negativism, acting in the exact opposite way that is being requested. He also was copying some of my movements. So if I touched my glasses, he would touch his face. If I touched my hair, he would do the same, which is called echopraxia. He had minimal speech, very soft spoken, whispering, like barely audible. And he wasn't attending to internal stimuli. He looked sad, and his MMSE was 15, which was better than you would think he would give given his other features of his mental status exam. He had a past medical history of 2 TIAs. He had hypertension, dyslipidemia, and coronary artery disease. He did have a past history of major depressive disorder, or maybe episode. He had enalapril, rabeprazole, ASA, and mirtazapine started. So his laboratory investigations didn't yield much at all. His TSH was fine. He had a chest x-ray, which showed nothing. He had a CT of his head, which showed small vessel ischemic changes and no big strokes. So the differential that I came up with was I thought he likely had a mood disorder with psychotic and catatonic features, but I wasn't sure. Certainly, delirium was still on the differential, major neurocognitive disorder, possibly a rapidly progressing. If you think about someone who's getting worse and functioning over a short period of time, over months. It could be a medical problem that we didn't know about and showing up as psychotic symptoms, or it could be a late onset psychotic disorder, late onset schizophrenia with catatonic features. So the plan was to address catatonia first. It was so we gave him lorazepam 2 milligrams BID. We ordered some extra blood work just for less common things, but things that are important, just like we talked about. And I did talk to geriatric medicine. They had known the patient, and they agreed to admit him. I agreed to follow along to be supportive. And I thought we might have to prepare for ECT if our thoughts about the catatonia and the depression were right. So that was on a Friday, and then he was admitted on the weekend. And on Monday, I got a call from the geriatrician who was taking care of him. And he said, this patient's fine. He's talking. He's doing all of his BADLs all weekend. His MMSE has come up 10 points. It doesn't look like this is a rapidly progressing dementia. It doesn't look like he needs ECT. So maybe we put a pause on those things. I saw him. I thought at the very least he might be depressed, but he was not. And his mood was quite good. The catatonic symptoms had resolved, and he was still experiencing auditory hallucinations. He could actually tell me about these things, though they were reducing over time. So we started quetiapine, 25 milligrams, QHS, and that was increased over the next few days. He had some insight into his previously held persecutory beliefs, which was nice to hear him talk about in the past tense. But 10 days into the admission, the geriatric medicine service called and said, your patient is all over the place. Please come and see him. So he had become fairly urgent, abruptly grandiose, talkative, racing thoughts, increased interest in sex, distractible, sleep disturbed. And he was asking the pharmacist for Viagra. So even though he didn't meet the time criteria, I felt like he was in a manic episode, which would change his diagnosis from bipolar or from major depressive disorder to bipolar 1 disorder. The differential, again, could this be medication induced? He's on the mirtazapine, but in the new parlance, it's not. That we think those are actually, we give a mood disorder diagnosis. And could there be a major neurocognitive disorder? That certainly was a possibility. And could there be a medical cause? Certainly, but less likely. So how do we treat mania once we diagnose it? So this is a little bit of a, this is based on the new guidelines from 2023, but also has a little bit still there from the 2018. We want to make sure that patients are safe as step one, that they're in the right spot, that we have a good diagnosis, that we know what their treatment history has been, what's helped and what's been not tolerable. We want to stop any medications driving symptoms, and the key ones are the antidepressants. And if there's any other substances on board that could be driving things, we certainly want to discontinue them as well. Step two is we want to start with treatment. So there's some bad news that the literature isn't as good for old people with bipolar disorder who are older. But in general, the 2018 guidelines anyway suggested using treatments that work in general populations, that they're likely to be effective in older adults without having the actual evidence. But there is some evidence which gives the CANMAT the ability to make some specific recommendations for the geriatric population. So we want to treat, anytime you're treating bipolar disorder, you want to treat the current episode. And so for manic episodes, first line treatment is either lithium divalproex. The second line is quetiapine. Third line are other atypical antipsychotics, some of the newer ones, and then carbamazepine, which is an old anti-epileptic medication. They give guidelines around treatment resistant that you can consider clozapine, and you can consider ECT as well. But when you compare this to the general guidelines, there's a lot more options given in the general guidelines, including first-line combination therapies. So that is not recommended in geriatric populations specifically. When we look going back to the younger or to the general ways that you treat bipolar mania, you either, if the first treatment isn't helpful, you try another first line agent. If that doesn't work, then you look at the second line therapies. If that doesn't work, then you can try a third line therapy. And you can see there are different combinations of medications, typically atypical antipsychotics, though some are older antipsychotics like haloperidol. And then there's some older antipsychotics as well, chlorpromazine, and tamoxifen is in the guidelines now in combination with mood stabilizers, and RTMS is now. And I also want to draw your attention to ECT. So we've gone through all this, but overall geriatric patients, when you think about differences in how we're going to treat them, lower doses, however, they often require the same number of agents for resolution of symptoms. So even though you don't feel too badly if you need polypharmacy, which is why I like talking about the general guidelines, because they give you better ideas for combinations of medications to use. Generally in geriatric psychiatry, we don't want polypharmacy, but this is one time where you may need to use it, and I wouldn't feel too badly. So for going back to our patient, there is what we did was first discontinue the mirtazapine, and then we increased the quetiapine very quickly. He was tolerating, he was on it. And luckily, even though this wouldn't be a first-line treatment, he did respond to it over 3 weeks. And so he was discharged home euthymic with follow-up. He never had another manic episode. He had some periods of hyperthymia, perhaps hypomanic. He continued on the quetiapine, but the real problem was the major depressive episodes. And so he had multiple admissions to geriatric psychiatry. Eventually, they did treat him with ECT. He responded. He was on ECT maintenance with a reduced dose of quetiapine. And he eventually it was clear he did become, develop dementia and required nursing home care. So just remembering about ECT, it's second line in bipolar depression, second line in bipolar mania, and it can be used as a maintenance treatment. Access can be a problem. And in general, so once people are well, what do you do? So usually you want to maintain, you want to treat, even if someone's only had one episode, you want to continue the medications that were effective in the acute phase, with the exceptions of antidepressants. You may need to lower the dose if people are having ongoing, longstanding side effects. And it's good just to know that most atypical antipsychotics help prevent the relapse of mania, and there's improved relapse prevention with a combination of lithium and atypical antipsychotics. We'll talk not about all medications that need monitoring, but there are a lot of the mood stabilizers do require some level of monitoring. And it's always important to support ongoing compliance so that people don't rebound. And then there's specific for general adults, some first line maintenance suggestions. So lithium, quetiapine, divalproex, acenapine. And so throughout this, I've highlighted the mood stabilizers in blue and the antipsychotics are in red, though I don't think I'm perfect in doing that. And so we're going to move on to case number 2. The patient was BD. This was one of Mark's patients. So I don't know her as well, but this was a 75-year-old married female. She had presented because she'd been started on sertraline for anxiety and developed a hypomanic presentation with increased mood, more energy, less sleep, impulsivity. She bought a sailboat, but she didn't have marked impairment in her psychosocial functioning. So she was given the diagnosis of a hypomania. She was referred to geriatric psychiatry for this. And when Dr. Bosma saw her, she was quite anxious. She described not being able to stop worrying. And she had features of a major depressive episode. She did not have suicidal ideation. There was no formal psychiatric history. However, on collateral history, her family described prior episodes of hypomania and mania. She had minimal comorbidities, but she did have hypothyroidism and was on Synthroid. She had no substance use. She had no family history of bipolar disorder, and she was retired, had one daughter, and had a very active social life. So the laboratory investigations that were done were non-contributory. The thyroid function was repeated. She had a normal CBC, electrolytes, kidney functioning. She had a CT. This is not a CT, this is an MRI, but the CT showed small vessel ischemic changes, which can look like this on MRI. It's pretty significant, small vessel ischemic changes. And not surprising given what we've talked about. The diagnosis was bipolar 1 disorder because she'd had previous manic episodes, but her current episode was depressed with anxious distress. So it's good to remember, we all worry about the damage caused by impulsivity and mania and the extreme behaviors we can see, but that people with bipolar disorder spend much more time in depression, and older adults probably spend even more time, which can be debilitating, cause a poor quality of life, a lot of symptom burden. So looking at treatment, what do the CAMAT guidelines say? They have, it's not as well laid out as for mania, but they have first consider category and then other options. We see a lot of the same, but some a lot of the same, but some different early options like using lamotrigine. Lithium is there again, of course, and antipsychotic lorazepam and quetiapine, which is well known. They do advise that you could use an SSRI or propion, but you need to use a mood stabilizer, and you want to be careful with how long you use the antidepressant because it can increase rapid cycling. And then some of the other, and then the ECT is also listed as well as divalproex and some of the newer antipsychotics. It's important not to forget that there are psychosocial treatments for bipolar disorder. So CBT is second line treatment. Family therapy has some evidence. Social rhythm therapy also has some evidence. And it's first line psychosocial treatment is actually education. So letting people know about their disorder, the things that trigger it, what the first line intervention is, what is expected of them for monitoring, and making sure, especially in older adults, that they have so significant support systems that can help them succeed in the illness. That can sometimes be a big barrier. But the mainstay for treatment still is pharmacotherapy, but using these psychotropic medications in the elderly can be a bit different. So I've alluded to the fact that usually you're using lower doses. And this is just because of the changes in physiology as people age. So people have less volume of blood, so there's increased blood concentrations. There's often less protein, so more is less is bound to proteins and more is floating free and available as an active drug in the body. And then the abilities of older people to get rid of these medications is often also reduced. And we know that people have increased adverse drug reactions when they're older. They're more likely to have extrapyramidal side effects to atypical antipsychotics. We see tardive dyskinesia more frequently. They become sedated, they become dizzy. There's risk of falls. The more drugs, the higher the risk because of the potential for drug-drug interactions. It's also really important to remember that, if you're familiar with dosing for some of these medications in dementia, it is different in bipolar disorder. So even though we're going to have lower doses likely than younger people with bipolar disorder, atypical antipsychotic doses are higher in treatment of old age bipolar disorder compared to dementia doses. So for instance, it wouldn't be abnormal for us to use like 275 of quetiapine in bipolar disorder, or 300 like Dr. Bosma did for a mood episode, for a depressive episode. But in dementia, we would use 25 milligrams BID for agitation or psychotic symptoms. Of course, that would be titrated up, but that's just to show you the stark difference. Again, caution with antidepressants, it can induce rapid cycling or frequent episodes of depression or frequent episodes of mood. And you just should be careful with monitoring. You want to monitor these side effects and look out for drug-drug interactions. So Dr. Bosma's patient was titrated up to 300 milligrams. Like I said, that's a little bit of a spoiler. She had no further obvious hypomanic episodes, but continued to have episodes of depression. There were no triggers, they were self-limited, and they were of lower intensity. So in order to better treat this, lamotrigine was added. So that was in the first option list. Slower response than expected. It's important to gradually increase lamotrigine because of the risk of a severe skin reaction, Stevens-Johnson syndrome. And it looked like she might have been a rapid metabolizer because the serum levels that he was getting were quite low. So just like, and with a lot of cases, there's lots of unexpected turns. And for this case, she fell and developed a concussion. She had some subjective mild symptoms, but in the wake of the concussion, she did have a suicide attempt that was high rescue potential, but still important to signpost because there is a high risk of suicide, 6 to 7% in the general population of people with bipolar disorder die by suicide. So Dr. Bosma brought in the family and they reported vastly different symptoms. So they reported she was actually still having episodes of hypomania, still having episodes of depression, but they were in this 6-week hypomania depression cycle. And they didn't feel like any help. There was not much help with treatment. The patient not reporting hypomania is not uncommon because it feels good. There's nothing wrong. There's not a lot of, by definition, there's not a lot of psychosocial strife associated with the elevated mood. And so sometimes these people can continue to have a diagnosis of depression when they have bipolar 2 or 1 if they've had a previous episode of mania. So this highlights the importance of involving family and getting collateral so that our patients can have the best treatment. And this is not always possible, but it is ideal. So she was having rapid cycling, which means you have more than 4 episodes of mood per year. This is not uncommon, up to 1/3 of patients. And she does have a risk factor for rapid cycling for hypothyroidism. So you want to make sure if people are cycling and just in general, you want to be checking their thyroid. But antidepressant use can make this worse, and substance use can make it worse as well. So the next thought was about treating her with lithium. So lithium is really Something that should be considered always. It is standard therapy in bipolar disorder. It's an active treatment for mania, depression, maintenance phases as well. Always think of lithium. It works best in what we think of as the classic presentation with this mania depression course. Might work better in people who've had fewer prior episodes and a family history. These are highlighted because they're part of our case. In geriatrics, you want to start with low dosing. You get this anyway, but you consider renal functioning because the risk of poor renal function increases in the older population. You want to titrate according to response and tolerability. So some of the signs of lithium intolerability are gastrointestinal symptoms, mild tremor, drowsiness. Um, uh, it is a medication with a narrow therapeutic window, meaning that it is helpful until it is not, and then can be risky. So that's why we get levels. It's very important that you pay attention to the difference in the levels for the geriatric population. You might think you don't need to do that because it will, of course, be written on the lithium level that you get from the lab. And unfortunately, there is no geriatric level on our lab reports in central zone anyhow. So this can lead to people being overly confident that people are not lithium toxic. I will say, you really do, if someone does develop toxicity, this is a serious event. In acute toxicity, people have a lot of severe gastrointestinal symptoms, coarse tremor, muscle weakness, muscle twitching, confusion, they're thirsty, they have urinary frequency. It can be it's toxic to the kidney and cause kidney damage. So you want to make sure that that you're thinking about the right numbers, and don't get too hung up on the numbers either. So if someone looks like they're toxic, but they're in the normal range, you should still think about lithium toxicity, unless it's like non-detectable. Sometimes also people have more chronic presentation and they can present with more cerebellar symptoms. So be aware of that slightly different presentation. You want to monitor levels after any changes between 5 to 7 days. And then once people are in a stable dose, every 3 to 6 months. Education is important with care partners as well as patients, because there's common medications that do decrease the metabolism of and the excretion of lithium. So, and not really the metabolism, but the excretion. So NSAIDs, they're available over the counter. So making sure patients know that this can significantly impact their lithium level is really important. But for our care partners, ACE inhibitors, thiazide diuretics and loop diuretics can all increase lithium levels. And it's also important to remember there are other things that can cause increased lithium levels, like where there's risk of dehydration, so heat waves, intense exercise, alcohol use, and that you should think of all of that when you think about your patient managing lithium. Well, I don't actually have much more content to talk about today. The idea was that we review the features of bipolar disorder in the elderly, and hopefully get some ideas and tools and resources of how to work with these patients. I want to thank you all for listening, and I'm really happy to take some questions.
Thank you so much, Dr. Mcneil. That was actually a really great, up-to-date summary of a very challenging disorder, and one that causes families, patients, and caregivers a fair bit of stress and strain when it occurs. If anyone has any questions and would like to put those in the chat box or put their hand up, we'd be happy to entertain those. Likewise, Elle has sent out the survey for attendance and for evaluation, and we would appreciate if you would send those back.
That's great. I will say, going through all this information, it can sometimes seem like, oh, that's just what you do. These are challenging. These are
Mm.
really challenging patients. You often don't get it right. You've got to be persistent and try different things. So,
And they
it's
often
not
require
easy.
close monitoring, right? And which again, I've certainly seen patients who have been on medications for long periods of time without monitoring, because of the current system, not because of any one particular problem, but because of the current system, and they can be very difficult to manage without follow-up. Donelda Edgar is asking if there's a standard order for blood work to rule out the medical problems.
I mean, I would say usually so for a late onset, I think getting imaging is fine. If that's an odd presentation unless you have someone who has you're highly suspicious that they've had bipolar disorder their whole life. Even then, I probably would order imaging. I would say standard blood work: CBC, lights, bun, creatinine, TSH, urinalysis if you have suspicious of delirium, chest x-ray again if on physical exam, and then everything else depends on what their specific comorbidities are, and do they point you in any other directions, again with family history if that points you in any other directions. So it's like there's like a minimum, and then there's add-ons depending on the clinical picture. I'm sure people have had difficult cases or questions around this. The biggest thing is this mania? That I would say is often a question. Is someone with delirium manic? Is someone with, and sometimes it's very hard to tell. And I guess another thing is sometimes as people get older, sometimes their manias actually do look a lot like delirium. Like a delirious mania presentation. And that is not fair to clinicians given the way that our system is set up, but it is what it is. And so there's no perfect place for these folks. It's impossible to sort out in the emergency room. And the resources on psychiatric units and medical units are vastly different. And I don't have an answer for fixing any of that.
Kathleen is thanking you for a great presentation. I'm sure you can see that, and is asking about if anyone knows how to access psychosocial supports for this group in terms of family psychoeducation or social rhythm or any kind of support systems.
I mean, I don't have, Kathleen, I would think of it as a little bit of a DIY endeavor. But our partners in the mood disorders clinic are really approachable. And just yesterday, I actually had a conversation. There was a patient who the psychiatrist in mood disorders had someone with mood disorder who developed Alzheimer's. So he wanted to ask me about my expertise. And then I got to run some things by about my patients. So I would use that team as a resource, but I don't know of any resources right offhand. Apologies there, Kathleen.
I would agree. It's one of the most challenging things in our system, is finding the support systems for individuals and for families.
Yeah. Yeah, yeah. So in the latest papers that I read about bipolar in the elderly, that the lack of lack of social support, the isolation, these are big factors in our areas missing from this care, which probably really impacts outcomes. Well, I don't hear wave of questions.
Oh, yeah, just saying, people saying thank you, and really again, thank you, Dr. Mcneil, really excellent. I appreciate the attention to detail and the use of cases to illustrate a complicated disorder.
And I want to thank again, the people that contributed to the presentation. It wasn't all
Yes.
my work, so I just want to acknowledge them again.
Yeah. All right. I think then we will. And if people do have questions that they don't feel comfortable putting in the chat box, please feel free to email myself, and if I can't answer them, I can forward them on to someone with more expertise. We're happy that you guys were here to join us, and we'll see you again for our next presentation.
Everyone.